is Katya Brossart. I'm a medical science liaison for Natera Oregon Health and a board-certified genetic counselor. I'm pleased to be presenting on this article entitled Biallelic Inheritance of Hypomorphic PKD1 Variants is Highly Prevalent in Very Early Onset Polycystic Kidney Disease. The authors are Miranda Durkee et al. From Sheffield University in the UK, and this article was published in Genetics and Medicine in April 2021, published online in November 2020. So to begin with a little bit of background, very early onset autosomal dominant polycystic kidney disease is quite rare. It may be diagnosed in utero or in infancy. By definition, it's diagnosed prior to 18 months of age. It is quite often severe and associated with a high recurrence risk for siblings of the affected individual. The genetic mechanism is related to reduced gene dosage, and biallelic inheritance of PKD1 mutations is thought to be the most common cause of PKD VEO. The authors here sought to ascertain the prevalence of biallelic variants in an unselected cohort. A little bit of relevant terminology to begin. So reduced gene dosage here refers to reduction of functional gene product. A hypomorphic variant is one resulting in partial loss of a normal gene function, often associated with reduced penetrance. A cystogene is one that, when defective, results in cyst development, for example, PKD1, PKD2, or HNF1 beta. Biallelic inheritance refers to variants affecting both alleles or copies of a given gene. Those in cis refer to variants residing on the same copy of a chromosome, and in trans refers to variants residing on different copies of a chromosome. The study design was a retrospective review of ADPKD referrals for diagnostic testing between 2010 and 2020 and included patients with onset of cystic kidneys prior to 18 months of age. So those of you who are at all familiar with testing for PKD1 and PKD2 over that 10-year period will be aware that there were significant changes in testing methodology over that period of time as more accurate methods were introduced. So over the course of the study, the testing applied changed. For PKD1 and PKD2, for example, bidirectional Sanger sequencing was replaced over time with next-gen sequencing with long-range PCR for variant confirmation. Additionally, over the course of the study, a 17-gene cystic panel was added. When we look at variant interpretation, sequence variants were assessed and scored by ACMG and AMP guidelines with multiple methods used to evaluate the pathogenicity. Looking at results, 53 variants were identified in 30 out of 36 patients tested. There were in total 47 unique variants found, 43 of those in PKD1 and 4 in PKD2. 16 of the 30 patients with diagnostic results had had prenatal findings, so cysts and/or enlarged echogenic kidneys seen on prenatal ultrasound. And 13, or 43%, had no known family history of ADPKD. De novo pathogenic variants were confirmed in 6, or 23% of 26 families with parental samples available. Looking at the results, those with biallelic variant combinations, those with a pathogenic variant and a hypomorphic variant combination, there were 16 infants with that pathogenic variant and a likely hypomorphic or missense variant in trans. When we look at the inheritance of the pathogenic variant there, in 7 cases it came from an affected parent, in 2 cases it came from a parent with a positive family history, and in 1 case it came from an unaffected parent with no family history. De novo inheritance was confirmed in 4 cases, and the authors were unable to confirm phase in 2 cases for which parental samples were unavailable. Looking at inheritance of the hypomorphic variant, It came from an unaffected parent in all cases with parental samples available. Looking at those with 2 hypomorphic variants, there were 5 infants in whom there were 2 likely hypomorphic variants seen in trans. In terms of digenic and monoallelic variants, there were 2 patients who had digenic PKD1 and PKD2 variants, and 1 had biallelic PKD2 variants and 1 PKD1 variant for 3 pathogenic or likely pathogenic variants in total. 9 patients also each had a single PKD1 variant, and these ones were considered by the end of the study to be genetically unresolved. Limitations of the study include the fact that clinical follow-up was not possible in all cases. So perinatal diagnosis of ADPKD due to ascertainment bias based on family history cannot be excluded in all cases. Also, there are some significant limitations with respect to interpretation of the variant. So likely pathogenicity of hypomorphic PKD1 variants can only be inferred, and that is because there are some considerable limitations of the currently available functional assays for PKD1. So in this cohort of patients with PKD of very early onset, there was a high prevalence, so 70% of biallelic variants among those who had diagnostic findings. And PKD1 hypomorphic variants were especially common. There were 5 infants with PKD VEO due to biallelic hypomorphic variants in trans. And interestingly, there were no pathogenic variants detected by that broader cystogene panel that I mentioned. Thinking about the impact here on clinical care, there are potentially important implications for reproductive counseling. So there is the high recurrence risk for siblings, so 25% if parents are heterozygous, and 40% of this cohort had no known family history of PKD. Also, there was a high incidence of de novo pathogenic variants, so those occurring in 23% of patients with diagnostic results. And definitely there is potential for implications for interpretation of variants of uncertain significance in young patients with PKD. Again, thinking about the difficulty of the variant interpretation for these hypomorphic variants and the possibility that those are going to be overlooked. Thank you so much for your time and attention in listening to this, and I hope that you will find the time to read the entire article. Thank you.